Good morning, good afternoon, and indeed good evening from wherever you're joining us from around the globe. My name is Tim Lane, and I'm Editor-in-Chief here at Surgery International. We're a free-to-access online resource which shares new surgical news stories from around the world. In addition to cutting-edge news stories, we also run features on surgeons, everyone from the space surgeon Scott Paraniski to the legendary transplant surgeon Sir Terence English. Our message reaches over 20,000 surgeons every week in over 150 countries. This webinar is part of our Talk Surgery series, where we focus on particular areas of interest in the field of surgery, and we invite acknowledged experts to what we like to think is a fireside chat about their respective fields. But of course, there is no fireplace, and if you do feel the warm glow of a fire, I recommend you check your house isn't on fire. Before starting, I'd like to thank our sponsors, who are Olympus, as well as Jones AV, which is a medical systems integration company, and thank them for their support this evening. Today's webinar is going to focus on the surgical options for men with lower urinary tract symptoms. To do this, we have with us a number of consultant urologists with an interest in the field, and I'm going to let them introduce themselves. Stephanie, would you like to start? Tell us a bit about yourself.
Hi, I'm Stephanie. I'm a urology consultant in NHS 5, which is in Scotland. I'm an endourologist with a specialist interest in minimally invasive techniques for prostate, both benign and malignant.
And Francesca.
Hi everyone, my name's Francesca. I am a consultant urologist down in London, so opposite end of the UK, at King's College Hospital. So my subspecialty interests are actually more quite broad, so core in addition to BPH. I do a bit of prostate diagnostics, and we're quite a busy trauma centre and a teaching hospital as well, so get involved in that.
And you'll notice there's a blank space on the screen at the moment, and that's for Christine Gann, who hopefully will be joining us later. She's currently stuck in traffic, but hopefully her picture will pop up at some stage later on during the evening. Now, one thing that's been obvious to both urologists and patients alike over the last few years is the explosion in the number of surgical options for men with low urinary tract symptoms. For patients and perhaps for surgeons as well, this has become an increasingly confusing field. And whilst we're used to MDTs for almost every aspect of benign and malignant urological procedures, from urogyne to prostate cancer, the option of an MDT for BPH is yet to get any significant degree of traction. So I wonder why that is. Francesca, why don't we have MDTs for BPH surgery?
Well, I think in my experience then, cancer care has predominantly kind of taken the lion's share of our MDT time. And of course, in an MDT setting, then it's not just time, but also resources, having a radiologist, a histopathologist, the relevant specialist nurse, etc. So I think one of the reasons in my experience why I think BPH may have been left behind perhaps is actually perhaps because men do have different options, but at the same time then they're not cancer cases, and some men, depending on which centre they're attending, may have certain limited options. So I mean, I think it's something that can definitely be developed in the benign field.
Yeah. And I wonder whether one of the reasons for that is because we've only ever had one feather in our cap. We've only often had just one option, and that's the TURP, and it's very much a, well, take it or leave it situation rather than a more nuanced discussion. I can see Christine's managed to battle through the A1 and has managed to go. Christine, just introduce yourselves. I've let everybody know you were stuck on the A1.
Apologies, Steve. So yeah, I'm Christine Gann. I'm very happy to be here today. I'm a consultant urologist at the Lister Hospital, mainly doing BPH these days.
So, and Christine, we were just talking about why we don't have an MDT for BPH surgery, and why do you think that is?
Yeah, I've been thinking about this actually because I think being the person who does most of the techniques at the Lister Hospital, I've often found I've had to make a lot of decisions on my own, and there hasn't really been a sounding board, which I would have appreciated. I think, as you said, you know, I'm the person who does most of the techniques, so who else am I going to have an MDT with is one thing. And apart from urologists, you know, MDT suggests multidisciplinary, and I'm not sure who else who else's input really would you know we need. So so I think that's probably why it's not common to have an MDT. But yeah.
Stephanie, one thing I know about you and your team in Fife is that you run a one-stop BPH clinic, which is perhaps a halfway house to that. Tell us how that runs.
So in a one-stop clinic, patients come through, we take a history and do a full examination and bedside test, which include thrust volume of the prostate, a flow rate, as well as a flexible cystoscopy if deemed necessary, if the patient is going down the minimally invasive surgical techniques, the missed options for BPH. We call the clinic one-stop clinic BPH clinic, and we kind of tend to reserve those clinics for patients who are going down the missed route rather than your TURP green light or HoLEP. And I think you're right. There's a lot of options there. We use the patient aid brought about by NHS England to help patients decide on which option. I am lucky to work in a unit where we are 3 urologists specializing in mist. So we kind of tend to have our own MDT. But I think that this is something that we may need to address in the future, and not too long in the future, actually. You know, female and functional urology have their specialist MDT. Many centers also have an endourology MDT. We certainly have that. And perhaps now is the time to introduce an MDT for BPH and perhaps link in with other units as well. As Christine rightly points out, if she's the only person in her unit offering these treatments, you know, it's helpful, I think, for her to have support from others who perhaps are in the same situation. And multidisciplinary, I agree, it's not just urologists. I think that our clinical nurse specialists who run BPH clinics alongside us can also be involved. They tend to have a more patient approach idea of things, so I think their input will be useful.
Okay, that's fantastic. So if we just to help the discussion go along a little bit, if we sort of run through some different scenarios, just very simple ones. And so I thought we'd start with one where it's a young chap, say 48, that seems young to me nowadays, with a benign 35-gram prostate. He's not responding to medication, and for argument's sake, he has bothersome urodynamically proven bladder outflow obstruction. So, Christine, so for me, this was bread and butter stuff when I was in training, and this chap, without discussion, was heading towards a BNI and perhaps a limited TURP. If we put aside other issues such as ejaculatory function, do you think that's still a reasonable option for someone? I suspect that's what's going to be happening in the majority of this country and around the world. Is that still a reasonable option, do you think?
I think in terms of improving urinary symptoms, that is certainly still an option.
Yeah.
But I think in this day and age, you would really need to discuss all the other options available and discuss ejaculatory function and things like that.
Yeah. So if we look into that a little further, what other options are open to this chap then, perhaps which might have less of an impact on his ejaculatory function? I know you've had some experience with Rezum, and perhaps you can tell us a little bit about Rezum and your experience with that, and what most patients can expect with the treatment.
So Rezum certainly is one of the options that would be suitable for a man of this age with a prostate of this size. Rezum, as many of you would know, is a treatment where steam is injected into the prostate, which then leads to tissue necrosis, prostate tissue necrosis, which over a period of time will then lead to a cavity created that allows improvement in flow and symptoms. So for men with small prostates, though, I often find that I prefer to do a flexible cystoscopy before subjecting them to or listing them for Rezum, because if it is purely a bladder neck problem, then Rezum wouldn't be the way to go. So I think people with just simply a bladder neck tightness issue should still have a BNI. So I think it's worth doing a flexible cystoscopy, because the other option for a small prostate is something like Urolift, for example, and then you would also want to know the median lobe anatomy.
Okay.
But the benefit of these procedures is the preservation of ejaculation, which would be achieved in more than 80–90% of patients. So.
Is there a sort of an optimum size? I mean, you're talking about doing a flexible cystoscopy. Are you going to do a volumetric assessment of the prostate? Is there an ideal sort of size for the prostate that you'd aim for?
I think anything below 30, I would be quite careful, and I wouldn't do Rezum on someone with a prostate larger than 80. I don't have experience in doing it in very large prostates, but I do know of people who have had Rezum for bigger prostates, so it's not impossible.
But for the majority of people, this is going to be for smallish prostates or men who want to preserve their ejaculatory function. Do you have a sense of retreatment rates? It's obviously minimally invasive. Many patients would prefer that, but these guys are going to have cathetered in for a little bit. Have you had a sense of how often these patients come back for further treatments?
So the literature suggests a retreatment rate of about 4% in 4 years. I don't know about the other panelists, but I think my own experience is that the retreatment rate is a bit higher than that. We haven't been doing it for many years. At the Lister, we've got about 2.5 to 3 years experience, and I think it's about a 10% retreatment rate in that sort of time frame of the patients that I've done so far.
So if I move on to you, Stephanie, I know you've also been undertaking Rezum treatments, but it's obviously not the only minimally invasive alternative. Urolift is one other, and I think recently there was a clear study which randomized patients to Rezum or Urolift, and what seemed to be clear is that the Urolift patients seemed to have a slightly better experience overall, with more rapid symptom relief, quicker improvement in flow, and overall better quality of life indices. So can you tell us a bit about your experiences with Urolift?
So Urolift is essentially devices that are introduced into the prostate via the urethra. They're nylon staples essentially that are clipped into the prostate and lift the prostatic lobes away from the prostatic urethra, increasing the diameter essentially and improving bladder outflow obstruction. Of course, this is an implant, so some patients may not be comfortable with having a permanent implant there. However, they can be removed if, for some reason, they create further symptoms for the patient, like pain and irritative lower urinary tract symptoms. In my experience, very few patients do go through those symptoms, but if they do, there is that caveat of being able to remove it. I suspect with any of these missed techniques, I feel that a flexible cystoscopy is absolutely essential, especially when considering Urolift, because you want to understand the prostatic anatomy. As Christine rightly pointed out, for example, whether there's a median lobe or not, that's going to affect which kind of mist you would offer the patient. The length of the prostate as well is something that you would also want to know in preparation for, say, Rezum, to know how many injections you're going to put in. And for Urolift especially, you'd also want to know how many clips you will be using.
Okay, yeah. And what's your sort of sense of what sort of sizes of prostate can be managed with this? I mean, again, this is a prostate which is ideally a little bit smaller. You occasionally hear stories about people trying them with much larger prostates, and unsurprisingly, with not particularly good results. What's your sort of maximum size you think you're going to get a good result from a Urolift procedure?
I think rather than prostate volume, I think of it more as what the anatomy is in terms of the lateral lobe protrusion into the prostatic urethra. Yeah. But overall, 50-60 grams is probably about right, because if the prostatic volume is larger than that, then there are better treatments that might give better longevity and durability of that treatment. And I think with any of these treatments, patient selection is absolutely essential for the device to work well, whether it's Urolift or Rezum or iTunes.
Yeah, and I guess that's that reinforces one of the most important thing is that there are plenty of people who are going to have a go at these techniques, but it's not necessarily the failure of the technique itself. It's just that sometimes they're inappropriately applied to patients, and often by people who perhaps don't really understand the background. So just doing the procedure isn't the be all and end all of it. One of the other techniques I know that you've had some experience with is iTind, which is this temporary implanted nitinol device, which essentially uses local ischemia to reshape the prostatic urethra. Can you tell us a little bit about that's relatively new for a lot of us? Can you tell us a bit about your experiences with iTind?
I think iTunes came into play as the last of the myths that we introduced to our unit. We do have some experience with it now. We've been doing it for quite a few months. I think it's a relatively easy procedure. However, we offer it under local anesthetic, although we can do it under GA. I think that the iTind is very good for the smaller prostates and for the younger men. You have to counsel the patient appropriately in terms of what it's going to be like for the week following the implantation of the device. The good thing is that it's not a permanent device that stays in, so quite a few patients actually like the idea that it's there for a week with a catheter and then it's removed. But you do have to counsel the patients that the symptoms will be getting worse over that week, the periods wherein the cage, the device itself, the iTunes device, is causing pressure into the prostatic lobes to create necrosis and open up the prostatic cavity, as it were. And as long as you counsel the patients appropriately and they know what to expect, many of the patients are fine with it. In terms of long-term data, there's not that much. It's still ongoing, but patients seem pleased, and we have had good results in terms of flow rates after.
So is that something you think about adding to your armamentarium, Christine, with your minimally invasive surgery, or have you got enough on your plate already? I think you might be muted.
I think it's possible to offer the full range, but I've often felt it might not be necessary to offer everything because, you know, they do similar things. So I would have to really look into what more it would offer compared to something like Rezum, for example, before adding another procedure in. And, you know, I'd be interested to hear what Stephanie has to say about that, really, how it differs from something like Rezum in terms of what the patient gets.
Well, Francesca, I'm going to change the scenario slightly now, and so we're going to worry less about the young men with ejaculatory problems, and we'll go for sort of a straightforward sort of a 68-year-old chap with a 70-gram benign prostate, again not responding to medication, and with bothersome urodynamically proven bladder outflow obstruction. So we start at the straightforward end. Is it still reasonable to offer this chap a TURP? I mean, I guess that's what most people will be getting around the world in units now, as it's still the gold standard. Do you think that's still a reasonable thing to offer a chap when he comes along to see you in clinic?
I think, of course, in an adequately counseled patient who is expecting a cavitating operation and expecting an improvement in his outflow symptoms, especially the hesitancy or the slow flow, then yes, I think a TURP, especially a bipolar TURP, is accessible for most units. So of course, I can only speak for UK practice, but most units would offer or would be able have the capacity to offer a bipolar TURP, and within the limits of NHS working then in a timely fashion. So we wouldn't want a patient to be waiting for a long time just for a specific surgeon that offers a specific operation. But equally, I do think that there are other options, and so this goes back to all the options that we would want to discuss.
Yeah. Well, we'll come to those in a minute. You mentioned bipolar. I mean, should we be doing any monopolar surgery nowadays, given that we have a bipolar option? And obviously the difference is between resecting in glycine and possible TUR syndromes. And even if you want to stick with a TURP, is there any reason to carry on with monopolar treatments when we can be resecting in saline and perhaps taking away that risk of TUR syndrome, however rare?
So we know that bipolar is safer overall for patients, and most of the units I have only worked in London and South East, they do all have bipolar. So there are some units which still do have monopolar equipment, and whether for some equipment issues, then occasionally that is required. And I know from other surgeons' preferences, I guess we're not discussing TURBTs today, but monopolar is still sometimes used for that purpose. But in my experience, then bipolar TURP is safer. And that's so we should be able to avoid the potential TUR syndrome. Yeah.
So I guess there's a question for everybody. Do you have a figure in your own minds, a maximum volume in terms of prostate surgery for TURPs? Is there a maximum volume that you wouldn't go above? I think for many people it would be 70, 80 grams before you'd be thinking about something else. What about you, Stephanie? Do you have an upper limit that you'd be happy to doing a TURP with or not?
I would agree to 70 to 80, especially when in our unit we are very lucky to have other options such as green light and HoLEP. But of course, I think that's not the same everywhere. I appreciate that other units may not have the resources that we have, or they're in the process of getting those resources. And I think TURP is a skill that all urologists should have, really. Even with a green light, if there's too much bleeding, you may need to convert to a TURP. So I think it also allows you to understand the prostatic anatomy doing the TURP technique that you may not necessarily gain by doing a green light. So from a training perspective, I think TURP is still something that should be taught. Yeah, as Francesca rightly said, the availability of that might not necessarily be there.
What about you, Christine? At what level do you insist they get the high-powered holmium laser out to do a bladder outflow obstruction? And when do you say, well, that's fine, I'll do a quick TUR? What sort of volume level is the cutoff for you?
I think overall, I would say 70, 80 would be the cutoff. But personally, the idea of having to sit through a 70-gram TURP is just a nightmare. Speaking as a HoLEP surgeon, I would much rather do a HoLEP on anything above 50, to be honest.
Yeah, I think
or indeed Aqua-ablation.
In our unit, if it's anything over 20 grams, I'll refer it on to Christine for treatment. So look, if I go back to you now, Francesca, so obviously laser surgery is rapidly becoming the gold standard in whatever guise. You, like many of the sort of newer generation consultants, are fellowship trained in laser surgery and HoLEP surgery. But if we start with sort of ablative PVP ablative surgery, what sort of what's your experience there? Do you use a green light, or is it another system for your ablative procedures?
So at the moment in our trust we use Boston, so green light laser PVP, and there are quite a few of us do offer green light laser PVP. So, I personally would, because of our setup and our trust, going back to resources and availability, we offer green light laser PVP potentially for up to 120 cc prostates. So perhaps a bit larger than some places would prefer. And that's partly because HoLEP is only available at a separate trust. I guess we haven't covered PAE yet, which is potentially something for larger prostates.
Yeah.
One thing we have to remember about green light laser PVP is not having any histological diagnosis. So if you're hoping for a specimen, then that's something that's lacking, which a HoLEP or a TURP can offer.
So in terms of who you offer a green light, who are you looking for? There's clearly specific groups of patients, like those who are on anticoagulants, because it's consistently has the lowest hemoglobin drop of all the interventions. But when you're trying to select a patient out who might benefit from a green light laser, who are you specifically thinking about?
So as you said, the patients who are more comorbid on anticoagulation, we do routinely continue aspirin throughout the operation if required. All of our cases are done as day case because we have limited main theatre capacity, and our day case unit closes at 8 p.m. So there's no overnight stay facility. So it's those patients who we know can safely go home with a catheter without needing irrigation. And we're also trying to run a self-TWOC, so they're taught to take out their catheter and they manage to do that themselves. So that's the main patient selection. And as I said, up to 120 grams. Occasionally, I'd been taught in my previous years that you can try to spare ejaculation with a green light laser PVP. I haven't got any statistics on how successful that is or not, but there you are able to spare some of the apical tissue to allow for some ejaculatory function, but I'd never advise a patient to count on that for future fertility. But
for you, Stephanie, then presumably you've obviously got experience in green light lasers. That's a popular and alternative in Fife. So can I assume that this chap going through your unit is much more likely to have a green light laser rather than a TURP?
Yes, indeed. TURP is still offered, but green light is definitely the mainstay for us, for those patients who have a prostate, anything between 50 to 100 in experienced hands. I personally would stop around 80, but some of my more experienced colleagues can do a green light with larger prostates. But yes, green light is the mainstay for us. And it's also used for those patients who perhaps have a smaller prostate and can go down the missed route of Urolift tightened or Rezum, but who would prefer to have durability and would rather not have the possibility of needing further surgery to to the prostate. Sorry, so that's the green light option is available for that cohort of patients as well.
Okay. I mean, Francesca, we'll talk in a minute about a larger prostates and things. Is there a minimum if you're considering HoLEP surgery now for this patient? I know there are a variety of maximum size and things, but is there a minimum size of prostate that you feel comfortable in operating on in terms of enucleation HoLEP?
So during my fellowship, I worked at a trust where we did not have green light laser PVP. We did have TURP. There was also a monopolar system, but not used for TURP. No Rezum, and the occasional Urolift in a very few select patients. And at this particular trust, there were 5 consultants who offer HoLEP. And so a lot of men did end up with having a HoLEP. And I think in my current practice, then anything from 40 cc upwards. I do find the smaller prostates more tricky to actually enucleate. And I know in the consultant's practice of my fellowship training, then their experience was that the smaller prostates often, or more often than the larger prostates, did end up with potential bladder neck stricture or bladder neck contractions at a later time. So I think that's something that's known. So I don't think we could adequately justify perhaps routinely offering a HoLEP on a very small prostate.
I can well remember an international expert being invited across to a certain august institution in London to demonstrate his HoLEP procedure. And on the day he arrived, they realized the patient they had selected had a prostate of about 29 grams. To watch him struggle was a struggle, to say the least. Christine, is that similar for you? Do you have a sort of a size at which you feel comfortable with? Obviously, in terms of smaller prostates, what sort of levels would you have a cutoff, as it were?
I agree. I wouldn't go below 40.
Yeah, it certainly becomes more of a challenge then, doesn't it?
Yeah.
So look, if we make things a little bit easier then, and let's change the scenario again, and we talk about say a 70-year-old man. He's getting older. He's been on the waiting list. He now has a 120 gram, 130 gram prostate. Again, not responding to medication, bothersome, urodynamically proven bladder outflow obstruction. So Christine, this is now surely the domain of the HoLEP surgeon. Even the diehards who advocate TURP are at this stage beaten. Okay, so the question is how big a prostate do you do? I mean, figures go up and up and up, but what's a reasonable size, or what's an unreasonable size of prostate you're happy to operate on in terms of size for HoLEP surgery?
Personally, I've gone up to about 300, and I've got a 350 on my waiting list.
Ouch.
So I'm prepping myself for that. But I know people who've done up to 400, 450. So I think it is possible. But obviously, you don't want to do that at the start of your experience. So
I mean, part of this is time, not just the enucleation, but the morcellation. And I suppose that at some stage you've got to ask yourself, how long is it going to be safe to have someone irrigated and under general anaesthetic or even regional anaesthetic? So it's not so much becomes not so much how big is the prostate I can do, but how quickly can I get through that, because that becomes then a safety issue. Is that similar for you, Francesca? Do you have a cutoff, and is that based on size, or is it based on time?
It's a combination of things. So it's also the comorbidities and the safety for the patient, and also what you're trying to achieve. So if it is an older patient who perhaps doesn't need the vestus flow but needs the void without a catheter, then there are options. In my experience, I definitely have not done a 300 cc prostate yet, but I have been a consultant for less than 2 years still. So that is something that I guess eventually I will work my way up to. but I know in some other trusts in London, then they do offer robotic simple prostatectomy, even for, and very rarely Millens for very large prostates.
Okay, fantastic. One alternative which we've touched on briefly is the role of prostate artery embolization, and that's not something, at least where I work, we have a huge amount of experience with. I know you were sort of talking earlier, Francesca, about trying to set up that service. How far are you getting on with that?
So at the moment, our PAE service, our elective PAE service, so rather than emergency for bleeding prostate or embolization, has been running for a bit less than 2 years. So we have 3 interventional radiologists who work with us, and in terms of cases going through for a PAE, then those are discussed at our standard benign MDT or our local MDT. So any cases that we do want to put forward for PAE will get a CT angiogram, and the radiologist will then discuss it with us. So, and then we follow up the patients afterwards. We're trying to work on a day case protocol purely for bed management and overnight beds, and reducing the number of patients who are cancelled, because of course they're not cancer patients, and most of the times they are safe with a catheter in or without a catheter and just having bothersome LUTS. So from that perspective, they are sometimes cancelled because of bed capacity issues. I haven't specifically looked at the data yet to know what the outcomes are, but it is an option which can add to those patients who are not suitable for a spinal or a general anaesthetic, who need some improvement in their symptoms.
Okay, that's fantastic. I mean, I think that probably covers most of the gamut of patients and size of prostates. And, you know, there's clearly a lot of options open, especially to younger men now with smaller prostates who are concerned about the sexual side of things and ejaculatory functions. And it would seem that there are much safer options and more definitive options with laser surgery, whether it's ablative or it's enucleative, with larger prostates. And obviously we're pushing back the levels each time and pushing back progress. So I'm very grateful for you all to join us to talk about that. If it's okay, for a few minutes, if we could just run through some of the questions that have come through, the first one is obviously one of the issues we've been talking about is knowing with reasonable accuracy about prostate size. And one of the questions is how do you assess prostate size? Because obviously a DRE is not particularly accurate. And if you're trying to work out whether or not you're going to do HoLEP or a TURP or whatever, how do you assess prostate size? Do you get some formal imaging, or do you rely on clinical examination? If I start with you, Christine.
So I personally would prefer to have a scan of some sort. These days, a lot of men do get MRIs before they get through to us, so that's useful.
Yeah.
But particularly for the mists, actually, I don't want to be doing a Rezum and find 100 cc prostate. So rather that way than, you know, finding something too big when I'm doing a HoLEP. That's not as much of a disaster.
And Francesca, do you put a formal bit of imaging in your sort of algorithm, as it were?
So most of our patients who are not on a 2-week wait pathway, who don't have a raised PSA and haven't had an MRI, will have a transabdominal ultrasound. Our radiology department don't routinely do transrectal ultrasounds, but in my clinic, I do have a transrectal ultrasound machine. So when I do a dedicated LUTS clinic, then I do try and do a one-stop model. This is something in progress that we're trying to get the registrars trained, because now they haven't learned in the generation of doing trust biopsies, then they're not really familiar with using a transrectal ultrasound probe to measure in clinic. But all patients should have a volume estimation.
But most patients, I suspect, will have an ultrasound of the urinary tract. And I suppose as long as you put in the request for a transabdominal volume estimation. What about you, Stephanie? Is that something that's part of your normal protocol to get a formal volume measurement?
Absolutely. I think it's essential to know what the volume is in addition to looking at the internal configuration of the prostate. So we carry out a transrectal ultrasound volume in clinic, unless, of course, they've had a transabdominal ultrasound, and we've particularly requested for the prostate volume, or indeed an MRI if they've come through the elevated PSA diagnostic pathway. But I agree with Christine and Francesca, it's absolutely essential to have that volume before, you know, seeing the patient on table.
Well, we've got a question here from probably a patient who's been listening in and is due for surgery, and I think he's elected for a TURP, and he's asking in terms of ejaculatory dysfunction, what's the percentage likelihood of him having ejaculatory function of a TURP? I'm assuming that most people would agree that that's going to be 90-95% plus for a TURP. Is that a reasonable figure?
Yes.
Yeah. Okay. So hopefully that answers that question. Someone's mentioned about patients now having HoLEP procedures and being asked to remove the catheters at home the following day. I know that happens in a few units. You sort of touched on that, Francesca, earlier on with your day case. Do you send patients home with catheters to remove the following day?
So we don't routinely opt for the following day. If the patient is having a Rezum procedure, then we'll go back to start with patient selection. First of all, we don't ask all patients to remove their catheters themselves. So there is a selection process that goes on. So the operating surgeon, today there was a patient that was deaf, and so we would want him to come back to clinic to have a formal trial without catheter, rather than taking it out at home and perhaps not being able. From that perspective, we choose the younger, fitter patients. Or indeed, say, for example, there's another gentleman whose wife used to be a district nurse. So from that perspective, you are safer. So as long as we know they're safe at home, we wouldn't ask them to take it out the day at 5 days or 7 days, and we would pick a day that's not the weekend. So we counsel them adequately and tell them that they need to remove their catheter at 8 or 9 in the morning. They have a phone number, they can walk in if they do run into problems, to take their catheter out at 10 days rather than 5 to 7 days.
Okay, so another question's come in, and we've talked about the importance of planning in all these procedures. And so if I ask you this one, Stephanie, someone's asked, do you think it's going to be standard to have a pre-op flexi for patients in the near future? Given that's going to help you see whether or not size of the prostate, whether or not there's a median lobe, a bladder neck issue, that sort of thing. Do you think that's going to be standard at some stage in the near future?
I think a flexible cystoscopy should be reserved for those patients who are going down the missed route, rather than patients we know have a large prostate, say, you know, beyond 80, 90, 100, and will be going down either the laser route or the HoLEP route, or indeed prostate artery embolization. So I think we should be aware that although a flexible cystoscopy is pretty much a bedside test these days, it is still an invasive procedure. There's still risks of bleeding and infection, and it's also invasive to the patient. So not all patients find it entirely comfortable. So I think it should still, we should still have some reservation about that, rather than subjecting all patients that come through the clinic for it.
So really just for minimally planning minimally invasives, that seems very sensible. Someone else has written in and saying, do you think we should have dedicated fellowship programs to train future consultants on all these aspects? In other words, you know, we have cancer surgeons being turned out to offer a number of techniques. Should we be having dedicated, more dedicated fellowships where you can learn all these techniques? Francesca, you did a bit of fellowship, as did Christine, learn HoLEP. Do you think there would be an advantage in actually running schemes where people can learn minimally invasive options as well as laser surgery? That's open to anyone. Christine, what do you think about that?
I think it would be, yeah, with all the techniques available these days, it does take a bit of time to learn the techniques, but also to learn the decision-making process. So yes, I think it is starting to go that way.
There's another question that's come in, and it says, I think I know where this one's coming from. It says, do patients undergoing HoLEP surgery need formal urodynamics? I think there are certain institutions where actually they're so confident about patients voiding afterwards that even when there are patients with significant degrees of an atonic bladder, they still seem to void afterwards. Do you still get urodynamics on patients who have large post-void residuals, or you're worried about a degree of atonic bladder? Francesca, that one to you.
In select cases, but most of the time in my experience, I have found that patients with chronic kind of low pressure, what we would typically call a low pressure bladder, they do still manage to void, which is definitely a good thing. So with a good cavitating operation, then they can still void. It is important, of course, to counsel the patients, and occasionally they still need to intermittently self-catheterize or afterwards, so that's something to be aware of. And of course, patients with high post-void residuals can end up with recurrent urinary tract infections and those kind of complications afterwards.
And Christine, do you like urodynamics with your patients still, or are you sort of somewhat equivocal and use it just selectively?
If we're talking about the catheterized patient, the patients in retention, then I think most patients do actually void after a HoLEP, but it's useful for people who have severe uritative symptoms.
Okay, I think there's just one more question now, and it's really about, it was mentioning the ITIND, so that one's for you, Stephanie, and I know perhaps you've just started using that, but they were talking about can you retreat after one treatment, and what sort of time intervals in there. So once you've had one treatment, is it possible to have a further retreatment?
I've never had experience of that. I think it's certainly possible. Because it's a device that's not lifted. However, subjecting a patient to the same treatment that clearly hasn't worked might not necessarily be the way forward. And we also have to think about durability. So in that case, we might advise the patient down a further different treatment.
That's right. And the very last question was to me, and it was, they've asked what's on my tie, and so if you can't see it, it's a globe of the world, and there's two scalpels running around it, and it's the symbol of the Travelling Surgical Society, which by chance has its 100th birthday this week. And it was formed by surgeons returning from the First World War to a variety of parts of the globe, and they all wanted to keep in touch with each other and to share stories and experiences, a bit like Surgery International. So perhaps that's a good note to sign off on. So I'd like to again thank our sponsors, Olympus and AV, and also our speakers, Stephanie, Christine and Francesca. You've all been fantastic. And thanks to everybody who's joined us this evening. And please join us for our next webinar next month. But for now, goodbye from all of us.